For those of you who don't know me, my name is Alexis Haslet. I am new to PPMD's care team. I work alongside Rachel and Amanda, and this is my first session presenting, so bear with me if I'm a little nervous. But we have some really great presenters here today, and I'm just going to kind of go down the line, have them introduce themselves, tell you a little bit about their specialty, and then we'll open it up to you all for questions. So, Seth, if you want to start us off.
Yeah. Thank you, and welcome, everybody. My name's Seth Sorensen. I'm a clinical neuropsychologist at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital. Neuropsychology, traditionally, again, we want it to be really incorporated into standard of care for PPMD. I know I get a lot of questions a lot of the times, and depending on where people are from, or even in the state of Arkansas, like how do we know that people encourage us to get it, but how do you actually access neuropsychology? Get those questions a lot. If you guys have any specific questions about what neuropsychology is, I'm happy to answer those questions, or if you guys have own personal geographical questions, I get those a lot, so I just wanted to mention that, but welcome, thanks.
Hi everyone, my name is Jaclyn, and I'm a rehabilitation medicine physician. I work at Seattle Children's Hospital. Rehab medicine is sort of this broad pool of what does that mean? In general, my job is to help you or your child do what they want to do. And sometimes that means thinking about equipment and bracing and therapies and all of those things. And I collaborate with therapists and the neuromuscular team to make those things happen. So that's my job.
Thank you. Good afternoon. My name is Andreas Barth. I'm an adult cardiologist and cardiac electrophysiologist. So I see patients with arrhythmias and see patients with inherited arrhythmias and also patients with neuromuscular disease, specifically also Duchenne muscular dystrophy at Johns Hopkins in Baltimore and also at Kennedy Krieger. And I'm particularly interested, besides studying heart failure in Duchenne, to also look at the incidence, so how common are arrhythmias in patients who have Becker and Duchenne muscular dystrophy?
Hi, I'm Diana Castro. My introduction is a little complicated because I'm a neurologist. I was with UT Southwestern for 14 years. I left them 2 weeks ago. I'm opening my nonprofit private practice to be able to see my patients and keep them until they're adults, so I don't have to transfer them anywhere, because in Texas it's a nightmare. Really, there is no transfer. The transfer from pediatric to adults is really limited. So that's why my name is, my place is different. I'm going to also do research. And that's the only thing I do, is I only see neuromuscular conditions. I don't see anything else in neurology, but just neuromuscular. So I've been living this for 11 years, very close to. Nice to be here.
I'm Dr. Kent Williams. I'm a pediatric gastroenterologist. I work at Nationwide Children's Hospital in Columbus, Ohio. I've been now, I think, coming to this conference now about 8 years. I talk a lot of crap. And I also talk a lot about trying to make sure that we maintain good nutrition throughout the lifespan. And then also, quite honestly, even my talks on things is not to treat constipation, but more of trying to come up with good bowel regimens and try to improve quality of life around both eating and toileting throughout the life.
Awesome, thank you guys. Does anyone want to start off with some questions? I can come around with the microphone. Anything burning? All right, I'll start and kick us off. Diana, since you were talking about transition with teens and adults, that's a huge pain point in a lot of areas. I worked in Kansas City, the Children's Mercy Clinic there before I came to PPMD, and we transitioned patients at age 22. But there was not a lot of places out there, especially when it came to insurance. Can you speak to any, besides leaving and creating your own nonprofit for adults, any other tips and tricks to transitioning? And Jaclyn, maybe you can speak to, or any of you.
So yeah, I'm going to tell you the bad example, because unfortunately I don't have the good example in Texas. So what has happened there is that 75% of the population has Medicaid. And we see everybody. We see, at Children's, I used to see people with Medicaid, with private insurance, whoever, came to clinic. We could not see people, undocumented people, or people without insurance, unfortunately. So the problem is, if you have all these beautiful team working so well, and we're creating all these new therapies and working hard to try to make our boys now more like Becker, who is gonna take care of them when they get older, right? And that's where I started suffering 3-4 years ago, when I started realizing that at 21 years of age, the patients with Medicaid, meaning 2/3 of the patients, were gonna be transferred to see a resident on the adult side, meaning a neurology resident, a person that is just training. Yes, there are doctors, but they don't do this every day. So to me, we went from here to here, and that resident will change every 3 years. So I started looking into it. I found, I look at many charts and patients between 22 and 45 years of age. And I found 160 something patients. Out of them, only 36 patients transition to the adult care. And when you look into, most of the patients were people with private insurance. So that's when I say something needs to happen. So I started working with the hospital. I was trying to get Parkland to create a transition of care clinic. I even offer my time. I say, I'll do it there. But, there is no funding. People say, we don't have money, we don't have how to do it. And that's when I figure out I'm just gonna do it by myself. So that's why I'm keeping my kids. And for now, we're on a break until I start my clinic in January. But hopefully my families will come back and we'll start working there. So what tricks, I just feel that everybody has to take the extra step, all of us. I mean, physicians and families, and push the hospitals, push the universities, because I felt that I was fighting by myself. I did not have support from anybody to try to go through. I had one physician in my hospital who said, worry about the kids, not the adults. And that broke my heart, because, so what's the point what we're doing, right? So unfortunately, no good tricks. Hopefully my place will work, and I'll tell you good tricks after.
I can't wait to hear it. Question for you all before Jaclyn. How many of you have talked to your providers about transition of care to adulthood? Okay.
Yeah, so I think we have a little bit of a different experience, which is maybe good. We are lucky enough to have an adult neuromuscular provider who is actually an all-star and is rehab by training, but neuromuscular fellowship trained also, so she is awesome. And so we transition most of our patients to her. We have some other neuromuscular adult specialists in the Washington region if we need to use them. And we've been trying to work on a nice transition process to make it better for our patients. I think that from the patient perspective, what we're also trying to really work on and build in our program is that transition is not just moving from a pediatric institution to an adult institution, right? There's a lot that comes along with transition, like things like the patient knowing their medications, or the patient advocating for themselves in clinic visits, and the patient making their own appointments, and sort of this shift of responsibility, right? And we should really, there's guidelines for this. PPMD has a beautiful worksheet on this that we're trying to start using in our clinic, but these are all things, these are conversations that we should really be starting to have in the early teenage years to prepare the patient and their family for what this transition looks like. There's lots of other things to think about around the age of 18, depending upon what your child looks like or what you look like, and if you're going to be needing help and things like this. And so I think that those are other transition pieces that we don't often always explicitly talk about. We explicitly talk about the move, the physical move, but those are important things to consider as well.
Seth, do you
if I can make a comment about that. The problem also is that it's the lack of knowledge too. Like, we had a social worker and a case manager, but nobody really knows the system. So I feel the families have to go and learn the system. They have to go through the system. That should be something that we should be doing for them.
Yeah, I think certainly trying to partner the team with the family to navigate all of this.
Yeah.
And I think that's where, like, having your team or not having transitioned them, it is very helpful. And I think that you know, it takes a lot of work. And so I know that we're working on this a lot right now. That also means you need people to do that work, right? So it just depends on what your center looks like. So those are the things to be thinking about.
Yeah, I would actually, I mean, I think my experience, and I think it varies probably quite significantly, and probably specifically to geographic regions, right? Different resources or parameters from funding agencies and those sorts of things. But I would say that my experience is very similar to, like in Texas, for instance, where we're working in a pediatric silo, if you will, right? And we're very hands-on. We're always making sure that at the next stage, we're doing some hand-holding and guidance and providing those resources, right? But as soon as they, you know, are starting to age out, 21, 22, they get kicked over to adult care. And despite all of our attempts to try to get that transition there, you know, funding stops. There's transitions into what state resources are available, and there's not necessarily a provider there anymore either. And just, you know, adult providers, I think, depending on their specialty, right, just might not be as hands-on either. So it can be very challenging. That being said, going back to what you had mentioned, it is absolutely crucial that we minimize that potential burden at the outset, right? So these transition plans, and it might be easier in my specialty of psychology, neuropsychology, to start thinking maybe more in advance, right? It's not necessarily we have to react to significant medical changes, right? Usually things are pretty stable from a neuropsych perspective, or as long as we're continuing to track and follow these patients with routine check-ins in clinic, we can kind of set the stage, right? So a good evaluation, we can think, okay, for the next 2 or 3 years, this is the roadmap to kind of follow, right? And so we need to start thinking about that. 12, 13, get that good transition plan in place, which is really required for, you know, parents, families, and the schools throughout high school, so that you have that plan, and then we can circle back once again, once we hit junior, senior year, like what is this next transition for the next 2, 3 years for that transition to adult care. So there's limitations, but absolutely, we need to think about it early on, early teens for sure.
Awesome, thank you. Yeah. And I'm checking my phone for the virtual, so don't think I'm texting.
I wondered if families are aware that there is a Duchenne muscular dystrophy transition toolkit, and PPMD has that on the website. You could bring that toolkit that has a checklist to your clinics, and potentially you could ask who's the social worker, the nurse coordinator, and what teams have identified those handoffs, and that should start around age 12. And there are kind of specific guidelines about what age the conversation should be happening across healthcare, planning for adult lifestyles, socialization, and whatnot. So it doesn't solve all the problems, but it gives you a guide as to what things might be helpful to think about.
I'll try and run as quickly as possible. So I was wondering, Dr. Castro, you were talking about you're starting this nonprofit, and so you'll, if I understood you correctly, you'll be seeing patients all the way through their care. Is that something that's becoming more mainstream? My son's 22, and we still go to Children's Hospital in Philadelphia. We're actually looking to transfer to Kennedy Krieger, so maybe he'll be seeing Dr. Barth there. But it's just like, I tend to most of my life be overwhelmed anyway, but the whole process of transitioning and is just like you all said, there's so much involved. And we also, you know, all of us who have been taking our children or adult sons to children's hospitals have established a relationship with their team. And as Dr. Sorensen said, you know, there's a little more hand-holding involved in pediatrics, and my son might not need that, but I think I need that. And so it's really scary thinking about transitioning and leaving behind everything we've ever known at a point in our sons' lives where their care is the most, you know, critical it will be. I was wondering if that's something that other hospitals are considering, you know, having the team follow patients all the way through adulthood.
I mean, there are places, Johns Hopkins has
Yeah.
that model, right?
Yeah.
They can follow the patient. UC
Colorado.
Davis has it as well, where
In
they can see the
Colorado, too.
patients. And again, do I think that that's perfect? I don't think it's perfect, right? Because now I'm gonna have to learn a lot of things about adult stuff. I was trained as a neurologist. We train as general neurologists, and then we do a special training in child neurologists. And I have to go back to retrain myself in that. But that was the only way to make it happen in our place, because there are no other really resources for the families. So I don't think it's perfect, but it's what we can and what we're trying. And yes, there are few places, I would say probably 3, 4, 5 places in the whole country that have that model, and it works really well. I think, what's his name? The neurologist, Jesus Christ, at Johns Hopkins.
So at Kennedy Krieger, it's
Oh,
Doris.
because you're Kennedy.
Yeah, it's
Yeah.
Doris Leung right
Yeah.
now, and before it was Catherine Wagner.
Yeah, but like Craig McDonald has that model.
Yeah.
And I think in Colorado they have it as well. So yeah, I mean, it's what every state can do. I just think that that's better than seeing, I'm telling you, when I review those charts and I found that only 36 patients transition out of 160 something patients, there's something wrong. We're not doing it. We're not doing a good job. So.
I have a question for Dr. Barth and Dr. Williams. Do you guys talk about transitioning with your patients?
Yeah,
at all?
so the model that we have at Kennedy Krieger is that there is a genetic muscle clinic, and the neurologist sees, it remains the same neurologist for pediatric and adult patients, and that's sort of the center piece, and obviously the neurologist becomes, like the primary care physician for those patients, and really a reference point throughout their care. Now, I'm an adult cardiologist, and on the pediatric side, there is a pediatric cardiologist. And so we rotate. So eventually, when they're ready to hand off the patient, and it really depends how much they like them, it can be that they hold on to them until they are well in their 20s, and eventually they say, okay, now I guess you have to. And then they come to me. And it's a seamless transition. We work together very, very well. And I think the fact that they retain their neurologist throughout their care, that makes it very important. And if you don't have to change your whole team, but only a couple of physicians, and it's within the same context, within the same clinic, I think that works well.
I like how you say it's a primary care, because that's how I feel. I always say I'm a glorified pediatrician. I just try to keep things checked, right? I check from head to toe and make sure things are happening.
Right.
So I think we can continue doing that job.
Right.
Having, obviously, older people like in the adult world, like you and you, to take care of all the other issues.
Yeah, the problem with GI, though, is the type of care that pediatric GI provides and the type of care that adult GI provides is very different. Pediatric GI, we do a lot of constipation, we do a lot of toilet training even, and things like that, and nutrition, evaluation of nutrition and things. That doesn't really happen in an adult GI world, where they're doing more screening for cancers, inflammatory bowel disease, liver, hepatology. Toileting and constipation, that's a generalist, really. And quite honestly, it's not adequate. I mean, I can't tell you how many times, even when I first started working, I don't mean to throw anybody under the bus, it's just a nature of the beast, where you do what you do, and you get really good at it in specialties, I joke that I talk crap all day, but it's not as simple as you think it is. It's not just whether you go to the bathroom every day. You can go to the bathroom 3, 4, 5 times a day and be severely constipated. In fact, if you are going 5 times a day, I'm really concerned that you're severely constipated. And I can't tell you how many times I've had a neurologist or a general practitioner or somebody say, oh, I handle the constipation in our clinic. And then I become a part of that clinic, and I go talk to the family, and I put a hand on the belly, and I find out the kid's completely fecally impacted. You don't come fecally impacted in 2 weeks. You come fecally impacted over months. So, it's different for GI. At our institution, I don't really talk about transitioning myself because I don't have someone to transition them to. Now, as for transitioning for the other fields, we struggle with it. We do. We do see a lot of people beyond 18. Fortunately, we're at an institution that allows us to keep seeing them, but that leads into a lot of problems. I mean, there's been a few young adults or getting into the 30s, I finally say, you know what, we need to find you an adult GI because unlike neurology, I'm not trained in adult GI. I got a 34-year-old right now, very likely has diverticulitis. I've treated diverticulitis 0 times in my life. So it's different for GI. And not only that, there's not a lot of GI doctors, pediatric GI, who really specialize in Duchenne's, and we're just really beginning to scratch the surface of really understanding what are the specific needs for the young men of being able to go to the bathroom. How do you go to the bathroom? You know, it's not a simple thing. No one wants to talk about it though. You know, I always joke that it's much easier for me to get a drug, sex, and alcohol history than it is a good poop history. So for GI, it's a little unique. We struggle with it. We struggle with it as individually, as a group, within GI, but at our institution, I would say we're kind of in the middle of the road of the two extremes where you heard that there's nothing seen after age 18, 21. Others were like, oh, we have got a great transition. We're probably in between.
But the problem with that also is that what happens if that patient becomes ill?
Right.
Like I had an issue at Children's, for example, the hospital I was working with one of my patients, 19-year-old, who had a testicular torsion, and they brought him to the ER at Children's, and Children's didn't want to take him. So they took him to Parkland. I'm like, it's a children's patient. It's a patient that still follow up with all specialists in children, but because he was older than 18, then they throw him to the adult side. I'm like, that's where it becomes, you know, the problem. So
No, I agree, because there's pediatric, I've seen, not necessarily in Duchenne's, but like malrotation. Pediatric gastroenterologist, pediatrician, a pediatric ED physician is going to get that like that. They go to an adult place that maybe doesn't see it that often, it can be life-threatening, and I've seen it do that. So I agree. It's a tough field, and it's not just within Duchenne's. I specialize in autism, trying to find, and for those who have both, MD, you know, that have Duchenne's and autism, I can't imagine. Because not only on top now you're talking the physical, but you're talking about the behavioral.
Hi. This is a question I've never heard discussed or anything before, but a parent was asking about bowel issues, and I had a discussion with someone that's in a wheelchair that has no other reason than that's where he needed to be. And he was having bowel issues, and he had a colostomy.
Yes.
And so we kind of talked about that, and I said, you know, I don't know if that's a Duchenne possibility, but I will ask the question, and we'll
Please
see
come to my
where it
clinic.
goes. So
Let's have joint conferences, you and me. No one talks about the possibilities. And that's why I changed from treating constipation, because the reason most young men develop severe constipation and impactions is because they never had anyone really talk to them about developing a good bowel regimen for someone in a wheelchair. If you have a kid who has spina bifida, you have a person who has a spinal cord injury, it's one of the first things they talk about. But in Duchenne's, it's never talked about. So yes, colostomy, not only do I am now starting to talk about it, I think it's a very viable, it's scary for people to think about. I get it. But the young men who have agreed with me and gotten it, it's been very freeing for them. They don't have to worry about being out in public and looking for a bathroom or having a stool accident. If you're living by yourself in an apartment and you have aides coming in only certain parts of the times of the day, you don't have to worry about that you've got cramps or need to go to the bathroom and they're not there to help you. You change the bag when the person's there. That's it. So yeah, And it's not for everybody. I mean, you got to talk about within the realm of what's your quality of life, what do you want?
I do drive my patients crazy about constipation. I do. We talk a lot about constipation and nutrition, but the problem is that there are so many barriers for them. Like, for example, they go to school.
Right.
And even my own son, he hates to go at school. He doesn't want to do it at school. So there is already a behavioral thing that, no, I don't want to do it at school. Okay, so I'm going to hold it from the morning all the way to the night. Or they don't have anybody who's going to help them transfer from one place to the other one. So how do you counsel that? Like you say a good regimen in a wheelchair, what will be that?
There's different options. If someone wants a oral medication regimen, there are times where we'll try to time dosing of stimulants, maybe 3 times a week. Give it in the morning, and it hits you later in the day, and that's when you do it. But those people have to have somebody with them all the time, right?
Yeah.
Again, it's very specific. What is your needs at this point? Ideally, I think, a colostomy can be, because you don't have the risk of, if you do it early, you're not having a lot of cardiac problems, a lot of respiratory problems, you can handle the surgery fairly well. The only problem is whether you're overweight. Then it becomes a little bit more of a risky procedure. So again, each person's different about it. So oral medications, enema regimens, there are different type of enema regimens. There's at least, I can think of right now, 3 different types of enema regimens that I offer to the patients. And you don't have to do it every day. There's actually a type where it helps irrigate the bowel. That's very good at keeping the colon cleaned out from the rectum. There's cecostomies. That's different than a colostomy. I've had one patient get it. The problem with that is you have to be able to sit on a toilet probably for 40 minutes to an hour. So if you're getting further into your condition and not able to sit well, then it becomes more of an issue. And then that, the colostomy, of course, is always a thing. Like I said, if someone has a car accident, I almost guarantee you within 6 months of them being in a wheelchair, someone's talking to them about their bowel issues. But we don't do it in Duchenne's.
Can I ask you a question?
Sure.
Some of the things that drove cardiology and pulmonary forward were clinical research and documentation, like, for example, using the MD StarNet data. And I've been saying for a while that I thought there needed to be a GI and GU conversations about looking at adult health care. And I know that our group had a urology paper because it's not just poop and peeing is another problem in Duchenne, older adults. And I would encourage the GI community, and it might need to be the neuromuscular people pushing to help get those access to that data. But I think there needs to be a big look at the patient population, and maybe that would drive the clinical change.
Yeah, you're exactly right. And we've done questionnaires and we've done things in the past. One of the issues, and I'd love to hear from parents, I'd love to hear things, because we just had a luncheon session where I got to interact with people and things. Again, talking to someone about some of the pulmonary support, talking about the cardiology support, there's a little bit of an education that's out there more, and it's a little bit easier to do. But again, you start talking about pooping. You're still laughing. People are still giving a little giggle right now that I say it, right? It's just a cultural thing we don't talk about. Because there's so much to it, too. It's like, how do you poop? To most people, as a doctor even, I was wrong in this when I first started in this field, too. I saw a person with constipation, they're severely impacted, I get you cleaned out, I get you started on a daily regimen. But it never dawns on me that you're dependent upon not only finding a bathroom, which can take you a while, but you're dependent on someone getting you on a toilet or on a bedpan. You're dependent upon someone wiping you, cleaning you afterwards. Those are things you don't want to do. So again, I think when it comes to this population, we need to talk about more, instead of treating constipation and stool accidents, bowel regimens, quality of life. What is best for you? Do you want the oral medications? Do you want the stimulants? Do you want the enemas? Do you want the cecostomy? Do you want a colostomy? Yeah.
Regarding the colostomy, is it reversible if the boys say don't like it?
You'd have to talk with the surgeon. Again, it's different in each person, because it also depends upon what your cardiac status is, the risk for surgeries and things like that. Mm-hmm. But yes, a colostomy is reversible if you really want it, but that requires undergoing anesthesia and a surgery again.
Another surgery.
Yeah.
And then Is there?
And you also have to, if someone's going for an LVAD or other things, you got other things to consider in each person a little bit. But a colostomy, the short answer is yes, it can be reversed. Not easily, though.
Is there a lot of complications at the site where it gets infected?
No.
No.
Studies done in patients with spinal cord injuries, the majority of them, vast majority of them, for instance, let me give you some numbers, that in some of the studies, young men and young women went from spending 20 to 25 hours a week on bowel regimens to less than an hour and a half. Colostomies rarely have infectious problems unless there's something else going on. It's like a G-tube too. People always ask about infections with those and things, but the chances of infection, if it's maintained well, is very low.
There was an online question for Dr. Barth about cardiac MRIs, and sometimes those machines are not super comfortable to be in. Can you speak to that a little bit?
Yes, I can. So what we know in Duchenne is that you need to monitor heart function, and we can do that in two major ways. One is to get echocardiograms. The other one is to get cardiac MRIs. The cardiac MRIs have the advantage that in addition to the what we call left ventricular ejection fraction, so how good the squeeze of the heart is, you can also look for scar. You can only see that on the cardiac MRI, but not on the echocardiograms. And this is where I differ a little bit with my pediatric colleagues, because when you're relatively young, contractures are less of a problem, and you're usually not on a ventilator. It's easier to accommodate you in a cardiac MRI machine. And unfortunately, there is no open cardiac MRI, so most of them are, or all of them are closed. So it is getting progressively more difficult as you get older and you have contractures to really feel comfortable in the cardiac MRI. And there are also different protocols. Unfortunately, the cardiac MRI protocols at times can be very long. It can be up to 45 minutes, and to be comfortable in a scanner for a prolonged period of time is not easy. So what is currently recommended is that you get cardiac MRIs every 3 years, and in between we get annual echocardiograms. And I have patients who are in their late 20s, early 30s, or mid-30s who are just unable due to contractures to get cardiac MRIs, and then we have to settle for other ways at looking at the heart function. Unfortunately, at that time, often echocardiograms also are not very informative, because for echocardiograms you need a good, what we call echo window. So you can't look through bone, you can't look through, with ultrasound, through the lung, and you can only see the heart in a certain position within the thorax. And as you have scoliosis and are in the wheelchair, it gets also more difficult to get a good look at your heart with an echo. And in my older patients, what I usually do is I also rely on the echocardiogram if I can. The cardiac MRI, obviously, if that's still feasible. If not, there is a marker that we can get from a regular blood draw, which is called proBNP, which is a heart failure marker. And that tells me how your heart is stretched. If the heart is stretched, the proBNP will go up, and that's a marker of heart failure. If I see that over time this proBNP goes up, that's another indication that the heart function is declining, and we should be a little bit more aggressive with medications. Yes, in an ideal world, that's the short version, we would love to get cardiac MRIs on everyone. If that is not feasible, we have to find other ways to assess your heart function.
Can I ask a quick question? Yesterday they were talking about gadolinium.
Mm-hmm.
So is it something that you have to do in every time, or not necessarily?
Not necessarily for every. There are institutions where you get cardiac MRIs pretty much on a yearly basis. You don't have to give gadolinium every year. Okay. There was a concern with gadolinium. So obviously in my elder patients, even a blood draw, sometimes it's very challenging to find good veins. And you can imagine putting an IV in and injecting gadolinium may not be that easy. But assuming that that's working, there's some concern with gadolinium and kidney function. If the kidney function doesn't work very well, if the kidney function is impaired, you should not, and particularly below a certain level, gadolinium is contraindicated. That was a problem with the old contrast agents. The newer ones appear to be safer from that perspective. And there are some concerns that gadolinium over time may also accumulate in certain organs, particularly the brain. We know that this is happening, but there doesn't seem to be any adverse effects of that. So there are no long-term complications from small amounts of gadolinium accumulating over time.
Can I ask a follow-up on the cardiac MRI? I am not familiar with the machine or the positioning of the patient. Is the tunnel too small to put like a support mattress or a beanbag or something that would be forming?
For most that's a very good question, and for most patients it works. But what you really need is a dedicated radiology staff who, that you're not the first Duchenne patient that they see. And they need to be familiar, what do I need to do? How do I make the patient comfortable in the machine? It's doable, but it takes time, and you really need a dedicated staff. Often when patients are said, oh no, I can't tolerate it, it's because the staff, you need to work together with the staff in radiology that they make the patients comfortable in the machine, and that's critical.
An open MRI is not an option.
It's not an option for cardiac MRIs, unfortunately.
And the position is lying on their back, right? I think
is,
that's
yeah.
part of it too. So then if you potentially have hip flexion, so knees are kind of towards the chest, right? And you're trying to lay on your back and you have to keep there for 45 minutes, an hour, or something like this, maybe longer.
Less, hopefully.
Okay. That's tough. So supporting with a wedge and trying to keep the knees together also might be a little bit challenging, but I think if you have a nice radiology tech that day, you get lucky, but that's the position that could be challenging.
I guess I had a kind of a follow-up question to that. My son, a patient of Dr. Omura's, has regular cardiac MRIs. He's only like maybe 4'8" and 94 pounds, and he has the same contractures that Dr. Omura is talking about, and his knees hit the thing, and they reposition him, and they have good techs who do that. I mean, I've got to think that there's people with much larger, like stature than him who have to go through those machines. Is it a matter of like a larger capacity machine or referral to an adult facility, or are there options? Because this is a really critical part of his care, in my opinion at least, and I guess consistent with our sort of the way this whole conference started yesterday, the cardiac initiative and so forth. Our boys depend on a significant amount of cardiac data. So just from that base level of what's this machine need to be like in these clinical settings where we've got kids who have bent legs, do we need to have a standard where they're equipped with larger machines, or what are the technical capabilities?
That is a very good question, and in general, if you go to a center where, a Duchenne certified center, I don't think this is a big issue. I think it's more of a problem if you go to hospitals where they're just not that familiar with neuromuscular disease. But I think it is really only at advanced age. So if you're in your 30s, this is where I really struggle with the patients to get them into the MRI. But before that, it's usually not a problem.
And kind of on the topic of positioning, I'm going to toss this to Dr. Omura. One thing that I don't think gets talked about a lot in older guys is skin, and when they're in certain positions for a long period of time. And can you speak to that a little bit?
Sure. So I think I talk about skin and these things in appointments frequently, especially as patients are spending more time in a seated position. And so some of the common problem areas are the bum and the sort of the perineal area, just from pressure itself. And so we often talk about, using your tilt back and using your recline several times a day to get pressure off of those areas. I think also from being in that seated position, those areas aren't getting very much air, and there's lots of kind of stuff going on down in that perineal region during the day, so we can get some extra moisture and things down there too. And so that's where sort of those reclines can be helpful to let those areas breathe and making sure we're getting good hygiene in there. I think the one that we are trying to be better about learning more about and thinking about more is sort of the edema that we see in the lower extremities throughout the day, and some of the skin changes with discoloration and things that you might see. So some families come to me and say, well, by the end of the day or a couple hours into the day, my skin's like looking a little bit red or looking more purple colored and things. And this is from blood sort of pooling in the legs. Our veins are the blood vessels that return blood to your heart, right? And they have valves in them. You could speak to this probably better than I can. But we need our muscles to squeeze those veins to open the valves and pump blood back. And so what's happening is you're sort of getting blood pooling in those areas throughout the day. And so it's sort of the same thing I've been talking about getting sort of your legs up, getting into a different position to get the blood returning back to your heart in a better fashion to limit those things. So those are the main skin concerns that I think that we see with being in a same position all day. And the name of the game is really like try and change your position as much as you can think about it. I usually counsel like try and think about it once an hour with the goal of 4 to 6 times a day, kind of getting that pressure off your bum.
Can I ask you a question about like toenails? That's something that Jesus, it's everybody.
Yeah.
And I never have where to send patients. Do you have any specific recommendation, or you have to send them to a podiatrist?
Yeah, so we try and manage stuff, right? Like ingrown toenails is certainly common. And so like foot soaks and trimming the nail straight and using antibiotics if we need them. But yeah, fungus is hard, I think especially because the options we have, like the topical treatments, take forever and they don't really work. And the systemic medications have side effects potentially on the liver and things. And in this diagnosis, it's hard to trend that because we have abnormalities in some of those labs anyways sometimes. So I think that's a really tough one. Sometimes PCP or podiatry is where we would use those resources.
Yeah, so are ingrown toenails common? Because I mean, I watch my son's toenails closely because I have a couple friends that have had this happen, and it's ugly.
A lot.
Yeah.
Very common, more than you wanted. And I have patients that have had infection, like really bad infection in their toes, and it has happened more than once in their lifetime, like the time that I have been following them.
Yeah.
So, and even without using shoes anymore and just socks and hydration and everything, the moms try to do so much and it still happens.
So can you kind of give us a little bit of a education in what to look for, right? Like when does a skin spot really start to look different? Like we've never had skin breakdown, but I can see that it might be starting.
Sure. So something that people might be familiar with is like when you're wearing AFOs, or if you or your child has worn braces, like taking the braces off in a skin, if there's a red spot, it should go away within 30 minutes. So that's kind of a nice thing to use. Like if someone's been positioned for a while and they're taking a rest and changing position, if they have redness, if it goes away within 30 minutes, that's a good thing. We want it to go away. The other thing is that we often look for in clinic if someone does have redness somewhere or signs that there is pressure, sort of pressing into the skin and seeing if when you take your finger away there's a white spot. We call that blanching erythema. That usually means we're in an okay spot and we can heal that area with taking pressure off. But if that redness is there, if it's getting a blister, or if that redness is turning dark, those are definitely reasons to like take a picture and send it into your care team or get some help with how to offload that area.
Thanks. I have one more comment. As we look toward getting older boys more involved in clinical research, clinical trials, it would be really awesome if the industry and the clinicians could work together to let these kids use clinical research as a care option. Start making those MRIs and those DEXAs and those blood draws happen one time and get all your information for both sides of the equation, whether it's a clinical trial, but make sure all the the draws also take care of their blood panels as part of their regular care. I mean, there's no reason why these guys have to go through these tests twice. So I think we could all do a better job of coordinating that.
That's a great point, and I have insisted on, like every company I talk to, I said the same, because the problem is they do the blood draws, and then in Epic system, in the electronic medical record, it doesn't come up as a result. So it says spin and hold. So then I have to go again and draw the 120 labs, and it doesn't make any sense. MRIs, usually we get a result that you can see, X-rays, you can see the results, PFDs, but labs is something that I many times have to repeat more than once just because of that issue. So that's a very good point.
Awesome. Dr. Sorensen, there's a question for you on here. If you could speak to managing anxiety in our teens and adults, that's something that I don't think a lot of people have the resources in their clinic to talk about that.
Yeah, so as everyone probably knows, right, last couple of years it's been tough on everybody, right, across the world, especially in youth. Mental health rates of mental health disorders, in particular anxiety and depression, have gone through the roof, right? These boys have always been more at risk for mental health issues and anxiety and depression, so it's definitely compounded these last few years. You know, some of the best things that we can do is be excellent models and take care of our own mental health at home, and there's definitely significant downstream effects from that. If you're followed through a certified PPMD care center, there's probably somebody who's checking in with you guys at those visits. I know all of us are stretched thin, but certainly if there's any concern that you have about big or small, right? No matter if there's been a change in mental health or whether you're not even seeing it, but you're wondering what to look for, you know, ask for that mental health resource that is in clinic. And if there's not a designated psychologist or a designated neuropsychologist, ask if you can get a consult from social work, if you will. Seeking treatment. Today's world too, because the rates of mental health issues have gone up quite significantly, there is an extensive wait list. So if we're seeing things go in a direction where things are increasing, we're having a hard time managing it, you know, we're better off going ahead and asking our primary care physician to go ahead and put in that referral, or asking for that referral as soon as possible from your provider. Of course, in those cases where mental health issues are getting to be unmanageable, whether we've tried therapy, we always recommend therapy be the first line treatment for anxiety and depression. If it's at a significant level, we're having big outbursts or panic attacks, those sorts of things, I would not hesitate to also get consult for medication management. All these things require resources, right? And ideally a psychologist can do the therapy, and a psychiatrist can do the medication management. There's wait lists, it's difficult to access those things, so you definitely have to, if you're seeing evidence of anxiety, depression, any mental health issues, it's kind of on you to bring it up to the provider in clinic, because when the medical provider, who might not be that advanced or sophisticated in identifying when we actually need to pull the trigger on a medication or refer for therapy, they might not be asking all those questions. So if there's been a change, you certainly are encouraged to bring that up to your provider and ask for the referral, because I don't see that it's automatic with a lot of medical specialties. And the limitation very well could be like, okay, even if I identify this thing, I don't have anywhere to refer them. That's not going to be a wait list for 6 months. So if you have concerns, you definitely have to bring that up to your provider, and ideally a mental health provider, as soon as possible.
I'm curious, in the audience, the guys or parents with older guys, how many of you are asked, like when you're screened when you go see your neuromuscular doctor, about mental health or suicide? Does anyone know? A couple? Okay. I was just curious. Did you have a question? Oh. Yeah. Oh yeah, can you talk about palliative versus neuropsychology?
Yeah, so I will say that that's something that I'm much less hands-on on, right? Our individuals are getting transitioned after the age of 21, and that goes through social work. I will say, at least in my institution too, that I'm the only neuropsychologist within, a couple hundred miles, so I'm stuck in the neuropsych silo quite a bit. Generally, again, myself and I think a lot of other mental health providers, even the social workers in clinic, we have to refer those things out. But it's about having all those decisions, those decision trees, like in certain situations, what the plan is at that end of life stage, right? Mental health can help walk you through that, but that's something I probably can't speak as much to.
I want to make a comment about that. Before I left, I implemented palliative care in the clinic, and I asked them to start coming. But then knowing like 50% of people are Hispanic, and I knew that it was a big challenge. It was going to be a big challenge. Trying to accept having a palliative care coming to see your son, for us in Hispanic cultures, we're giving up. And it requires a lot of education and a lot of patience and, talking and talking. And I think that as neurologists, we should start that work way earlier than we do. So not only just bringing them, but just introduce the concept of palliative care since early.
I have a question for Dr. Omura. Just from a rehab perspective, can you talk about the difference between transitioning treatment from a child to young adult or adult, and anyone else obviously can touch on this as well?
Yeah, from like a therapy perspective or just the whole? Yeah, so I think, when we think about therapies and this diagnosis, it's different than how I think about therapies in a child that I take care of that has had a stroke or something, right? Where there's like some event that happens and there's a change in sort of functional status or what their ability is. Whereas in this disease process, we're all very well aware of this like progression, right, that happens over time. And so I think we're very therapy intensive in the beginning to keep and get stronger and maintain. And I think that as patients get older, we do a little bit of shifting. We do a little bit of having a perspective and a shared goals conversation with families about like where priorities lie. And at some point in the teenage years somewhere, usually that conversation looks like talking about sustainable ways to move your body at home and doing things that you love and really that quality of life piece. And so I often find that in my older patients, weekly therapy with PT and OT and the whole kit and caboodle and let's like really work out hard shifts more into like stretching programs and getting out for long strolls or whatnot with family or taking trips and things like that. And so I think that those therapies become important to make sure that we're managing contractures as best we can and stretching programs and DME evaluations or equipment evaluations. And those things usually happen in adult centers because adults have things like strokes and other things that happen to them. And so usually adult therapists are fairly well equipped to handle the needs of this patient population. Does that answer what you're asking? Okay.
Yeah. I have a question for Dr. Castro. You mentioned that, like, as a neurologist in this kind of like disease population, that you kind of act like almost like a primary care physician as well. So in my current position, like I see a neurologist, but I see her out of state, and because I'm not happy with the people in my local area, and we formed a relationship. I've been seeing her since I was like 7 years old. But I also would like to have some doctor locally as like a primary care physician in case like something pops up and I might need a referral that my neurologist out of state wouldn't know about. So, and I don't know like what's the process of going to find a good PCP for someone in our community, because in my experience, most PCPs have like no prior experience with a person that has Duchenne.
That's a great question, and it's something that, when I started working at UT Southwestern, there were certain families that will go only to Cincinnati, and they didn't have any local care because there were issues before. And something that I tried to start doing is for those families to start seeing me at least once a year. I don't mind sharing care with anybody. It's not about me, it's about you guys, right? So I think that the effort has to come from the neurologists, really, because the PCPs are seeing patients. I'm sure a primary care physician doesn't take more than 15 or 20 minutes to see you. And a patient with Duchenne cannot be seen in 15 minutes. So it will be more ideal for you to find a neurologist, somebody that you can use as your primary care physician for most things. There are going to be things that are out of scope, but we can make referrals as well. So I would say my ideal situation will be that you can continue seeing your person, but hopefully find somebody in the adult side that can start kind of keeping an eye. It has been helpful for emergencies. It has been helpful when the ER calls the neurologist and they call me and I can answer that question. They are not going to be able to communicate with Dr. Brenda Wang in Massachusetts, right? But they can call me. So I think that that's where we should be moving towards, making a better effort, having a good local care.
I think.
I come across this quite a bit because, as I said earlier, there's not a lot of people that do what I do, even within the pediatric world and the adult world too. And I understand where you're coming from in the sense that I agree. I would try to find a local neurologist if you can. And I usually would encourage someone to look at the years of experience that they've been practicing. Try to find someone a little bit more senior because wisdom comes from experience, and experience often is the result of lack of experience. Experience comes from a lack of wisdom. So that would be the first thing. But if you don't find someone you trust, because what I heard you say earlier, it made it sound like you've looked for someone locally, but you just don't trust them, which is a big issue. Other avenues that I've looked at for some of my patients and things to find someone outside your field of expertise, but may have some within, the two things would be if you're near an academic center, if they have like a complex medical care center where they have patients that see more than one or two specialties, and these people are used to taking care of people, maybe not Duchenne's, but with cerebral palsy, other developmental disorders, multiple congenital heart disease and pulmonary problems, multiple problems. Someone who's comfortable with that. Another thing within the field of medicine, I feel like for people who feel a little bit more, somewhat better trained, maybe, I don't know, but they just feel more comfortable taking on more challenging cases. If you can find a local practice, if you're looking for a PCP, MedPeds trains people. One of the best physicians and family things we ever had in Nashville was a local internal medicine, pediatric trained primary care physicians. They're trained in both pediatrics and adult. And so sometimes, particularly, they may have more experience with their pediatric patients taking care of somebody with developmental and complex things, and therefore they're more able to take care of the adult too. So those are things I would look for locally if you were looking outside of neurology.
I don't know how common it is, and I don't know if you guys know how common it is to have these complex clinics in the adult side. Is it something that you guys have? You do have. Because the problem with my complex clinic is that we start hitting each other's head like all the time because they recommend things that are not appropriate for a neuromuscular patient. So then they go and put braces in my patients with hip weakness, and it just drives me crazy. So we're contradicting each other, and that's where the patient is getting, and I don't think that's fair. So I don't know what's the right. I mean, I like your answer
but what
of
I'm
the
saying
med
is find
peds,
someone that's willing to work with someone
that
like
will
us.
exactly.
That's what I mean. I mean, I think the best doctor is a doctor that knows their limitations. Mm-hmm. If you can find a doctor that knows their limitations, willing to work with other people, that's what you need to find. And that's where I'd say look for, and you also want to look for someone who feels comfortable in taking a very challenging patient on. I mean, I'm sure you see it in doctors' eyes all the time. You go into a clinic room and they see you come in and you just almost kind of see them tense up, right? Well, you got your answer, right? So, yeah. That's why I say look for the more experienced people. Maybe they had more experience. But I think the real reason to look for experienced people is they're a little bit, that wisdom that comes from the, experience comes from the lack of wisdom. They've screwed up enough times that they realize they're not as bright as they think they are, and we're willing to help reach out to other people and work with people, I think, you know.
And I think you start losing your ego after you start getting
Yeah,
older.
exactly. That's basically what it comes down. You lost your ego.
Yeah, so you don't care. It's not about you, really. So you
You know,
collaborate better with
I deal with crap all the time, so I lost my ego a long time ago.
I think that was an excellent question, and I think probably across any and all specialty, we hear that same kind of thought, right? But it's different if you live in, you know, Dallas Metro or some big area, right, where there's all these different places. If you're out in rural America, right, there's maybe only one provider, right? There's only one option for you. We're trying to get into mental health providers or getting into that one neuropsychologist or whomever, right? It's not always an option, in which case, I will say, even when I first started working with this population, all of a sudden, you know, I knew PPMD was out there, and I actually started looking at the resources. I'm like, oh my goodness, like just honestly getting an overview of all the amazing, wonderful, well, you know, put together resources online takes 5 minutes, and all of a sudden that has given me the amount of information to be confident into knowing like at least how I should go about approaching this patient, right? Or at least a couple additional questions to consider, or what it ultimately means to be a patient or a family, you know, living with these different, you know, challenges. So I would also encourage you to not be afraid of providing resources to the physicians. And I would say that maybe that's where having a younger provider sometimes takes less offense to being educated sometimes, because I've gone in for my own medical thing and I've, you know, asked a question because I've done all my reading, and not all physicians are always wanting to hear that, right? Like we spend a lot of time in our education to know what we know. I think some people feel challenged with it, but you guys know more about what you're living with than anyone else, right? Arm yourself with that information and provide your providers with those resources as well. I think it's very helpful.
Yeah, I don't mean to disparage anybody who's coming straight out because, you know, a younger person, because depending on where they trained at, they may have trained at a place that had a Duchenne clinical care center, and they may be the most trained person there is. I think you have to look at that too. A little thing about the rural area, a little bias. I grew up in a rural area. Sometimes rural country docs are some of the best docs because they lost their ego a long time ago and realized they need, you know, they're just overwhelmed with everybody in the area coming to them with things. I think, you know, if you're in a rural area, I think developing a relationship, I think everything in medicine is based upon relationship. Find somebody you relate to. Find somebody. Don't necessarily come in prepared with a whole stack of like, here's what I want or whatever. But maybe start off with like, okay, can you just tell me what's your familiarity with Duchenne's? What have you done? I'm looking for someone to really help me on my journey. If you approach it that way, I think you're going to get a lot more response from the doctors.
I have the mic, but somebody else has their hand up, so. I have the mic.
Christina can.
Yeah, that's it. Just to recap for those online, Christina was talking about sharing medical records with the primary care provider. Is that a basic overview of your question?
Yeah, I have a question that's unrelated. Do you have any advice or any recommendations about the use of hand and finger splints?
Yep. Yeah. So this often comes up sort of later in the disease process where you or your child is spending a little bit more time in a wheelchair, just from the positioning, like we've talked about, the hip flexion contractures. Although I've seen it occasionally in younger boys who are still ambulatory, but the main things that we look for are or what I'm looking for, what is their resting position? Like, what do their fingers look like when they're resting? And if they're starting to be really in this like curled position, we're starting to think about splinting. The other thing that I'm looking at is how close can they approximate sort of this prayer position. If they can get fully here, their range of motion is great, and we're not thinking about wrist and finger splints. But if we're starting to get farther and farther apart, those are things that we're looking for to think about initiating finger or hand splints, usually at night. And I think that some of the common questions we get or problems seen is like, well, if I'm wearing hand splints at night, like how am I gonna go to the bathroom and how am I gonna like readjust things? And so sometimes that looks like one a night. And some of my patients decide that it's better to be doing those things during downtime, like during their screen time or when they're not gonna be using their hands quite as much.
Well, I mean, the leg splints became problematic because they were heavy.
Right.
So my son doesn't, he's almost 21, he doesn't wear his leg splints anymore. He wore them, he was very good until he was about 18. And then we got a new pair and they were slightly different and they were heavy, and we're fortunate that he doesn't need to be turned at night, but those splints were heavy enough that they were a problem. So even the hand splints are heavy.
Yeah, and I think I have a mic problem. Okay, I can yell. So I think this is a discussion with your team and your provider, right? Like should all be team decisions. There's risk benefits to these things, especially with splints and bracing. And so it becomes about what do we want to do? How tolerable are they? If they're not, then talking about what that means. And does that mean that you might lose function sooner or get tired sooner? And if you're a gamer or
My son's very afraid of losing his hands.
So, these are things to start talking to your providers and your occupational therapists in clinic about troubleshooting. Like, when can we get these on, or what stretches can we do, or how can we make this work?
Thanks.
Yeah, it's not easy.
It is a negotiation between the physician and the patient, no? At the end. Because if you tell, that's the other thing that also physicians that are, in the younger is like, you have to do the 2 braces. I'm like, nobody's gonna have 2 braces, it's too hard to sleep. So then you start giving up and it's just do 1 every night, or just take the weekends free, right? So it's a lot of negotiation, and I try to involve my patients into that negotiation. It should not be only with the parents.
Yeah, I think a lot of it too, for physicians, when we're first trained, we're thinking like, we got the answers for this condition. You got problems with contractures, you use your splints, you use your things. We forget about what it means to keep those on, them being heavy, being clumsy with, and things. It's quality of life. I think that's where a senior physician, you really learn that your job's not so much to cure a condition. This is not a condition we can cure. Our job is, in anything we have, there's anything we prescribe, anything we tell you, there's complications. Try to think of those. Try to think of that. I don't want my recommendations to be worse than your current quality of life. Quality of life, that's what we should be looking for.
Just a quick one with the hands, that curling, because my grandson's a gamer. I wondered too, just about rolling up a washcloth or a hand towel and just putting that in to kind of keep that spacing instead of necessarily having to wear a brace. I mean, just household things maybe that we could use.
It's certainly an option, and they have there's a foam roll also that can be used. If he's working with an occupational therapist, there's many different options to be talked about.
Awesome.
Good idea.
This question, I think, is for Dr. Barth. Is that right? My son is 18, and he has he's got Duchenne, but he also has an aortic root dilatation, and it's the ascending aorta, I should say. Curious to know if you've seen that, if it's been anything that's common with a child that has a condition like Duchenne, obviously with the heart being a muscle. And also, if you have, he's actually at a point where his aorta is eventually going to have to be fixed. So he'll have to have open heart surgery. They're watching it, they're monitoring it, but I'm not sure about the medications, if it could be making it, I don't know, speeding up the process or slowing it down. And if there is a recommendation or something that you've seen that would help, slow down the progression.
Mm-hmm. Yeah, no, that's a very interesting question. And first of all, is it related to Duchenne? The answer is no. So I don't typically see dilation of the ascending aorta in Duchenne boys or young men.
Yeah, I'm sorry, I should have told you that too. It's hereditary, and when he found out that he had it, my husband also has it, so it is.
So that was exactly my point. So unfortunately, when it happens, this is a disease that you see the dilation of the ascending aorta that usually you see with aging and with long-standing hypertension. If you see it in younger men or women, then it's usually there's a hereditary component. So then there may be two different processes going on, Duchenne and then this hereditary aortic aneurysm. And what can make it worse? It's hypertension, that's one. And the medications, the very medications that we use to treat Duchenne also have a beneficial effect on the aortic aneurysm. The one medication that is particularly useful are angiotensin receptor blockers. And for instance, losartan or valsartan, those are medications. For instance, if you have another condition where you have this dilation of the aorta is Marfan syndrome. And we know that those medications, the angiotensin receptor blockers, they work very well on minimizing the growth of the aortic root, but also help the heart muscle to stay strong. So that would be great medications to be on. And then it's keeping the blood pressure as low as possible, or at least preventing hypertension. And last, the indications for aortic root replacements vary significantly. If you have an inherited condition, like Marfan syndrome, then you replace the aortic root at a much earlier stage than what you usually would do if this hereditary condition was not present. So to be in a genetic testing for aortic root disease is also important. So in addition to Duchenne, there are connective disease, cardiovascular clinics, they focus on connective tissue disease. That would be a good idea to be seen there, and having at least annual follow-up of the aortic root to determine when is the best time to replace that. And in patients with Duchenne, obviously, that is a major surgery. So thinking about, there are just a few centers in the United States where I would feel comfortable that there is sufficient expertise there to undergo such a surgery, A, from the aortic root, and B, from a rehab perspective afterwards, that you really don't lose all your ability, what you have right now. So when...
Which centers?
Oh, we can talk offline. I don't want to recommend anyone here, but there are a couple of cardiac surgeons that really are world-renowned experts in aortic aneurysm. And then it's not only to have that surgeon there, but also to have the expertise from a rehab perspective afterwards. I've seen patients with relatively minor surgeries, like a pacemaker, defibrillator upgrade, with Becker, who afterwards, they were done somewhere else, and then they lost ambulation afterwards because they didn't receive the proper attention to their rehabilitation afterwards. And for a major cardiac surgery where you need to open the rib cage, the thorax, that becomes really at least as important as the surgery itself.
Also, so they can know how that rehab is going to be different from other patients, right? And what we shouldn't be asking those patients to do. So, that's a great point.
Okay, I came in late, I apologize, but I wanted to address mental health, Dr. Sorensen.
Mm-hmm.
I was hosting what was called Porch Nights, and I did a mental health, and I had over 50 moms come on. And it was exhausting. And I had Dr. Natalie Truba and Jessica, I'm here, my friend, also come in because they have a lot of input on the subject. And when I tell you that there wasn't enough room for 2 weeks for these parents to just, my kid has this, and including my son, he was tossed out of his wheelchair, broke his femur, he has anxiety. So on my note, I was told, I go to Nationwide. Nationwide said they wanted me to have a follow-up with a psychiatrist in our area that he's taken the medicine. So it was so hard to find the doctor. I had to pay $600 out of pocket and come back every 3 months and pay $175. And it was a drug den.
Yep.
And I'm bringing my kid into this, psychiatrist office, but he brought Tanner in, looked at him for 2 seconds, didn't even ask, how are you? Just, okay, here, go. I mean, it was just crazy. I ended up calling back Nationwide, and I told them, and they've been wonderful since, they get it, and I'm monitoring. Oh my God, I have a meeting. I'm sorry. But there's an urgency, and we're shorthanded and short-staffed in this subject because,
Right.
it was exhausting. And Dr. Truba was, she was on for almost 3 hours, and we didn't even get to 10 people, and from ages 3 to 26. I had a mother in India calling about her son. It's just bizarre, but what it showed me is you guys being the main doctors in this group, if you can find references and resources, I know I don't want to put anything more on you because you're all we have, but we got to do better. And we really have to raise the ante. And then one other thing was clinical trials and manifesting carriers and girls. There's nothing for our girls and manifesting. We had another one, and I had 30. I wasn't even aware how bad a manifesting carrier can get. And there's really nothing. I know UPenn just opened up one for moms, but that's something else that is a whole other door of things that need to be addressed. I could sit up here and go on and on, but if you guys could get resources and really try to figure out, because I know you're a dime a dozen, and it's rough out there.
Yeah. And, going back to, I'm actually impressed with our rehab docs and our neurologists in clinic and how many of them are actually, I think, in certified care centers and probably stand alone, that they're willing to take on that role of kind of PCP in managing these other medications, if you will, and having to step in and maybe overstretch, I'm not usually comfortable prescribing these types of medications, what can I do here? And again, that's where them arming themselves with as much knowledge and you guys preparing that knowledge, right, and educating them also, really, again, kudos to all these other medical specialties that are willing to overstretch, stretch their own specialty out to hit on some of these mental health areas, because absolutely there's a shortage, and not just for the kids but also for the parents and families as well. We have to all pull together and be as resourceful as possible.
We wish we could replicate you. This next question is for Dr. Williams. What are some subtle signs that there's issues with swallowing and or digestion they should look for?
So with swallowing, it can be very difficult to really find, but the things that we try to focus on in the clinics is not just swallowing, but just feeding in general. Swallowing itself, with respiratory, would be, of course, the things would be choking, gagging with feeds, particularly with more thinner liquids and things like that. Any kind of chronic cough, even maybe, would be another thing that I would want to know about if I'm concerned about issues with swallowing. Unfortunately, sometimes you don't know until if you've been diagnosed, keep getting diagnosed with respiratory issues. Usually a good pulmonologist will pick up on that too, and things like that. But we try to expand beyond just the swallowing, as in okay, how long you taking to eat? What are you starting to avoid meats because you can't really chew them well? How do you feed? Are you feeding yourself? Are you dependent upon other people? because, again, quality of life, trying to find a way of keeping your good nutrition, particularly in the later years. So, because if you become severely malnourished, there's no studies, but I'm convinced that if you're rapidly not able to keep enough intake in and you're maybe requiring more because of effort to try to breathe and cardiomyopathy and things like that, it's very important to keep an eye on that weight that's going on. Because when the kids get to 18, 20, a lot of times people don't use the growth chart anymore. They just look at the weight. So I encourage people to watch at least every 6 months weight and see how things are trending. If you're starting to trend downward, we really need to start addressing some kind of supplementation. And G-tubes are not a terrible thing. They can be extremely helpful. You're not taking away feeding. You're not taking away things. Again, we're talking about quality of life. And almost every patient that I've required, there's only been one patient that's really not liked the G-tube afterwards, but even when I talked to him about trying to take it out, he agreed that having it was better than being without it. So we start looking for those subtle signs. Weight, how you're eating, and then just chronic cough, any kind of choke, gagging. Are you starting to avoid, liquids? Are you having problems? Or the other flip of it is, if you swallow a solid food, such as a steak or a meat, are you having to drink to try to get it to go down and those things?
How often we should be, this is part of the questions, right? Are you choking? Are you having any difficulty swallowing? But do you recommend to have video swallow studies done more?
No, not video swallow
often?
studies, unless your screen is positive. I don't really, again, video swallow studies are you can get somewhat, depending on where you're at and what institution you're at, if they see some kind of like thin penetration but not frank aspiration, they may overreact to it. It really, to me, the first step would be a speech therapist, not a swallow study.
Awesome. We've got about 5 minutes left. Any last minute questions from anyone in here?
I'm finding this topic to be upsetting because I see that my son is starting to struggle with certain foods, and he refuses to acknowledge it.
Yeah.
He's deny. That is not happening, Mom. Can you cut my meat up smaller? And it's already like tiny.
Yeah.
Really gravitating toward mashed potatoes, pasta, meatballs. I can tell he's having trouble.
Yeah.
But to him, it's like his hands. It's like, I'm not giving this up.
Again, a G-tube's not giving it up. The numbers, again, I don't have any specific numbers in research like I do for the colostomy and time you spend, but I can tell you the amount of time needed for eating and focusing on eating and things, if you're starting to spend 45 minutes to an hour eating, you're probably not getting as much calories in as you were before, and need to watch the weights. When I talk to people about G-tubes, two things I talk about is we're only going to supplement, you're still going to eat. And the ironic thing is, a lot of the young men that we end up putting a G-tube in and doing supplementation, it's not uncommon in the next 6 months that we cut back on that supplementation. They all of a sudden start getting more energy, able to eat better, able to chew better, they have more reserve. And then we don't take the tube out, we just keep it, and we kind of meet every 6 months and we just make adjustments to what we're supplementing because we don't want to make them too heavy, we don't want them getting too low. But the G-tube has been very beneficial. In fact, in bowel management, it's very beneficial for that. It's easy to do a clean out. It's easy to give medications, extra fluid. To me, a G-tube, and it's a very small thing. It's not like a colostomy bag where it hangs out a lot and that's got to be some of the self-view. A G-tube is very, very beneficial to someone who is having difficulty with the fine motor skills, and if they have cardiac issues and pulmonary issues and they get sick, you need to be able to give fluids during that time to keep them out of the hospital. Very beneficial. So we're not taking anything away. What we're talking about, again, you heard me harp on this all the time, is trying to improve the quality of life, because I really think that's what's really beneficial with that. And a G-tube, as compared to the colostomy, that is way easy to reverse if you really don't like it.
So, this whole conference is like, okay, we want to promote independence, but yet these guys need so much care. And, you know, we're talking about adding this and that and a G-tube to maintain, or it's just a lot. I mean,
Yeah, but I would say in these
it's overwhelming
situations.
to think about independence and then to think about all this other stuff that they're going to need medically.
But in these situations, if you're talking about not getting enough nutrition or spending an hour to 2 hours getting adequate nutrition in each meal, what we're talking about is trying to decrease their dependence on other people and decrease their dependence on medications and other things. We're actually talking about in these instances, it can actually improve your independence.
Okay, I mean, I'm taking it all on board, and I really appreciate the theme, but you know, it's also making these kids understand the seriousness of doing these things. If they're going to be in charge of their own care, they really need to consider things they don't want to think about.
Right, and in the last conference I was in, that's what I was asking parents about and stuff. It's like, because what I really don't like is when I get a call, I'm not always in the neuromuscular clinic. They'll schedule me if they know there's someone that wants to see me or whatever. But the call I dread every time is being called to come see a young man because they think he needs a G-tube. And almost every time, it's my first time meeting the family, the kid is severely malnourished, and I come in like, yeah, I mean, I would rather have a relationship with you and give you this information up front and develop a relationship so you know that I'm just not coming in and telling you, all right, we're going to change things drastically. No one wants to hear that. And you're going to be faced now to, you're going to feel lost. You're going to feel, you know, concerned about having to go under surgery and things like that. I mean, I think the best thing to try to do is try to realize, and you were asking me like how often to do these things. I mean, the recommendations right now for discussing like swallowing and for nutrition is every 6 months. And to be doing it from early on. The problem, of course, is I don't want the visits to be around, okay, sometime we're going to have to do this, because not everybody gets this. Not everybody gets a G-tube. Not everybody needs aggressive bowel regimen and things like that. But to try to give the information of like what to look for. And that if that happens, we got something that can help you.
Awesome. Thank you guys so much. You all are absolutely wonderful. You guys had great questions. These people will be around if you want to follow up. I'm offering your services to the families. So I think we have a break now and then a main session in the main room. So thank you all.